All right, ma'am. So welcome to India Top Doctor. As you know, today we'll be talking about maturity onset of diabetes of the young, that is also known as MODY. But can you tell us what is MODY before that?
Actually, it's a collection of inherited form of diabetes, which is the early onset of hyperglycemia, means higher blood sugar during the early age, of life. That is called as MODY. It is neither type 1 diabetes nor it has type 2 diabetes. It doesn't have autoimmune, insulin antibodies or GAD antibodies over here, and neither it has features of insulin resistance or obesity. So this is a different entity altogether, which is a monogenic inheritance type of disease, which is responsible for defect in insulin secretion, basically, and resulting in hyperglycemia. So the prevalence of MODY is almost 1 to 5%, globally. So it's a rare disease as compared to type 1 or type 2 diabetes. But it is important because it is often misdiagnosed as type 2 diabetes. See, you know what is type 1? Total insulinopenia, means because of the autoimmune destruction of beta cells, there is no insulin at all. But these type of people, though they are non-obese, they look like type 1. They may be like type 1, thin, lean, but they have insulin in their body and they respond to the treatment with oral anti-hypoglycemic drugs too. So range of, there is wide phenotypic variability, like, the patient may have mild symptoms of diabetes to when it progresses further, patient may develop pancreatic insufficiency and over may develop ketoacidosis too. So therefore it should be diagnosed in time. So genetic scanning of this disease is also very important part of the treatment management of the MODY. Yes.
All right. So what causes maturity onset diabetes of the young? If you can tell us about that.
Yeah, first of all, before talking about the genetic basis of this disease, I would like to talk about, what are the different, features like we should look for in a patient by suspecting this disease. Like, suppose a patient, is having persistent hyperglycemia of early age of onset of diabetes before 25 or 30 years of age. Patient does not have, insulin resistance symptoms or does not have insulin antibodies, very strong family history of diabetes. Like, it is an autosomal dominant inheritance pattern of the disease. It has got. So what does it mean? Like, it runs in family, like grandfather to father to the child. So this runs in successive generations. So that is very important feature of this disease. And besides this, like suppose some people, they are being treated as type 1 diabetes. These people are found to, in type 1 diabetes, we suspect to have some kind of autoantibodies, I told you. These people, they don't have those autoantibodies too. They have detectable insulin level, which we can measure by C-peptide, which is a measure of insulin production in the body. So there is a detectable C-peptide level in the body too. And on top of that, associated with some kind of other organ abnormalities like kidney, genitourinary tract abnormalities too. They may have so these are the features which are exclusive to this kind of disease. So first in 1990, one first MODY gene was diagnosed, MODY gene was diagnosed, but later on only almost 14 subtypes of this MODY has been found. First study was conducted in 1975 by Faison and Durter. So at that time, what they suspected, the person they were being treated as type 1 diabetic, they were able to respond to the treatment with oral anti-hypoglycemic drugs too. Okay, and these people, they didn't have the features of insulin resistance. Either they did have obesity, either they did have autoantibodies for the insulin. So that's how this MODY came in picture. Now, what should we do once patient comes to us, So I would like to talk about a little bit of genetic basis of this disease. it is a monogenic inheritance, means a single gene mutation is responsible for the disease. So there are different subtypes of this MODY. See, first, once a person is diabetic, it can be of two types, polygenic inheritance or monogenic inheritance. If there is polygenic inheritance, we suspect type 1 or type 2 diabetes. And if it is monogenic inheritance, we suspect either neonatal diabetes mellitus or MODY. In MODY also, if there are defect in enzymes like glucokinase enzymes, so that is a type 2 MODY. Okay, so and if there is a defect in the transcription factor, so this results in major people suffering from MODY, they belong to this type of group. So there are hepatic nucleoside factor 1 alpha, which is responsible for this kind of defect in the body producing MODY, and hepatocyte nuclear factor 1 beta in another type, and hepatocyte nuclear factor 1 4 alpha also, and insulin promoter factor is also there. There is other in other type, you don't find any genetic abnormality, so that is called MODY X. So genetic mutations are very important part of diagnosis of this abnormality. And how do we detect this? So genetic testing, genetic sequencing is a gold standard for this, but it is very expensive. So there are other methods also. So we detect by genetic counsel. We do the genetic testing, and then thereafter the genetic counseling with the patients.
All right.
So this is one thing. So basically, what the cheapest and available method, which is economical, it is called as DHPLC, which is a denaturating high performance liquid chromatography. So this is a cheaper method which is available for the diagnosis of this disease. Okay, sorry, I've had some phone call. Okay, so basically, as I told you, it runs in families. So suppose somebody is having a leaner father suffering from diabetes with the early onset of diabetes, and grandfather too suffering from diabetes who doesn't have the morphological features of type 2 diabetes, which is insulin resistance, acetosis nigricans, or fatty liver disease, non-alcoholic fatty liver disease, or patients is not having any kind of metabolic syndrome. So these people are, we can highly suspect MODY in such patients. Actually, in fact, in recent past, in recent 1 month, I got almost 4 patients with a similar characteristic. So I'm going to, going to investigate these patients. I'm convincing them somehow. I have convinced them for C-peptide levels too. So in one patient who is 5'6", 5 feet 9 inches, very thin, and she's just 37-year-old, and her C-peptide level is 0.8. It is neither type 1 diabetes, which is less than 0.3 something, but it is not like normal level of type 2 diabetes. Normal in our type 2 diabetes, we get a C-peptide level more than 1.1 nanomole per liter. But here we can get, if there is total pancreatic insufficiency, we can get lesser C-peptide level, but normally it is around about 1 nanomole per liter or 0.7 nanomole per liter, like that. So this is also a very important part of diagnosis of the disease. Suppose the person comes to me and I have to investigate that person. How do I do that? So patient is having hyperglycemia and certain type of MODY, like glucokinase defect, MODY with glucokinase defect, enzyme defect. These patients have fasting hyperglycemia rather than postprandial. मतलब खाली पेट उनका शक्कर ज्यादा है rather than खाना खाने के बाद का, like that. So we suspect, then we have to see the investigate for the insulin autoantibodies, GAD antibody, IA antibody. If then ketones, if the sugar is very high to 75 something milligram per deciliter, and the C-peptide level, as I told you. Suppose the patient is falling in this category of like ketoacidosis is there, autoantibodies are there, and patient is lean and thin, acute onset of disease. So we suspect type 1 diabetes in such patients. And the patient is, not having acute presentation, patient is BMI is high, patient is having signs of insulin resistance, we suspect type 2 diabetes. And in between, like normal BMI is there, patient is having, successive family history of strong family history of diabetes, we suspect MODY in such patients. We have to investigate accordingly. And this, there are different enzymes also involved in MODY. So one is glucokinase, which is responsible for almost 20 to 22% of MODY cases. And hepatic nucleoside factor is responsible for almost 67% of MODY cases. So MODY 2 is there, MODY 1 is there, MODY 3 is there, there are different types, and this glucokinase, when this enzyme causes MODY, so it is very, this deficiency of enzyme is very common in pediatric age group. So early diagnosis of this kind of conditions is important, but this is not related with severe hyperglycemia. These patients are having milder hyperglycemia. They don't have, usually they don't have microvascular complications too. So they can be treated with simple, dietary management, meal management, as well as some exercises like low carbohydrate, low fat, low calorie diet is useful for management of such patients. And some patients that do require sulfonylurea treatment, like as I told you, MODY 3 type of patients, and specifically when patients develop pancreatic insufficiency, that time patients needs to be treated with insulin. Okay, in glucokinase deficient MODY, which is MODY 2 type, in this, when the patient becomes pregnant, that time maternal hyperglycemia can cause, as I told you in GDM, this can cause macrosomia, means large for gestational age baby. To prevent this and to manage this, to avoid the microvascular complication in fetus, so we have to treat this patient with MODY 2 also, with sometimes during gestation with insulin to manage the hyperglycemia. It's like that. Okay.
All right, ma'am. So can you tell our audience what mutations causes MODY?
Yeah, as I told you, there are different types of mutations, like, transcriptional factors. These transcription factors are important for the, these genes are encoded for certain proteins, which are important for the secretion of insulin. So suppose these having some kind of mutation in this kind of genes, transcription factors, they have been mutated, so that protein is insufficiently present for to induce the secretion of insulin. So there is insulin secretion insufficiency is there rather than insulin resistance. So this is hepatic nucleoside factor 1 alpha, as told you, responsible for the majority of the cases of MODY. Then there is hepatocyte nuclear factor 1 beta also, which is responding for less than 1% or 2% of MODY cases. So 4 alpha, HNF 4 alpha is responsible for almost 1% of MODY cases. See, the basic reason, when we investigate these cases, we have to differentiate between the phenotypic variability and genetic, to correlate the features, phenotypic features, means what are how the person is, morphologically, what are the different symptoms. As I told you, in MODY 2, the patient doesn't have a severe hyperglycemia. It can be easily managed with the diet, exercise, and sometimes insulin too during gestation. While this MODY 3 type of, if there is progressive hyperglycemia, patient may have microvascular complications, so they should be treated properly. So they can be treated with the oral anti-hypoglycemic agents, and when there is a severe deficiency, they should be treated with the insulin too. And there is another type of, I told you, HNF1 beta type of genes, when it is affected, there is certain patients, they complain and they say, madam, humko cyst ho gaya, renal cyst, kidney mein cyst ho gaya. So these patients, they do present with renal cyst first, then they are diagnosed to have diabetes. So they have genitourinary tract abnormalities in this kind of patients. They have, pancreatic exocrine insufficiency also in this kind of patients. So these patients are like, they are also present in early 30s. So we have to detect so that we can prevent these kind of abnormalities in time.
All right, ma'am. And when can one suspect MODY?
As I told you, like, before, like the patient, as I told you in, in the beginning of this interview, I told you, okay, the patient is having progressive hyperglycemia or sustained hyperglycemia, whether mild, moderate, or severe. But onset is generally before 30 years of age or 25 years of age. In fact, MODY, this MODY 3 type of, it presents early adolescence, during the puberty years, because so there is variety, it is not like that it cannot be present later in life, but mostly below 30 years of age. And there is strong family history of diabetes. Patient does not have the symptoms of type 2 diabetes like acanthosis nigricans, insulin resistance, dyslipidemia, hypertension. So that's how we suspect. Even in type 1, the patients who have been treated with type 1 diabetes, suppose they are responding to oral anti-hypoglycemic agents for almost 2 years, so we can see whether really they are type 1 diabetic or they are having some genetic defect related with MODY. Okay, so there is autosomal dominant pattern of inheritance in these patients. Yes.
All right, so we get the idea of that. And can you tell us how is early onset diabetes treated?
Yeah, see, the goal of treating MODY is to prevent complications, to prevent hyperglycemia or hypoglycemia, to achieve the glycemic targets. Okay, so how do we do that? Normally, 1/3 of patients that respond to diet, low carbohydrate, low calorie diet, low fat diet. 1/3 of the patient they respond to oral anti-hypoglycemic agents. Okay, and almost 1/3 of the patient they require insulin for their treatment. So it depends on the genetic type. Accordingly, doctors take decision regarding the treatment of the patient.
All right, thank you so much for giving us a deep knowledge in a lesser known concept, ma'am. Now, do you have any message?
Yes, it's very important because patients do come and mujhe kaise ho gaya diabetes? How I'm not obese. I don't have any kind of bad habits, lifestyle problems and all, and still I am suffering from this. They are taking good care. They are doing yoga. They are doing exercises. They are walking, maintaining themselves well. Then also they do have this problem. So we have to. So my message is like whenever patient walks to you, when patient is very young, patient does not have features of type 2 diabetes, please suspect MODY in these patients and please investigate and give them proper genetic counseling and convince them for genetic counseling, because these are little expensive tests. Patients are literally sometimes they're hesitant to go about go further in the diagnosis, the depth of the diagnosis regarding the cost of the investigations and all. So that's why we have to diagnose it early so that we can avoid the complication related with MODY.
All right, ma'am. Thank you so much. Very well said. Thank you so much for joining us today.